Are we? Yeah. Okay. So we are going to be talking about safe sex, safer sex today, sexually transmitted infections, STIs, and also pregnancy prevention. This is the first time we've tried to do this remotely. Usually we do this in the live classroom. Melanie Gill, who's our guest presenter, was here with us last year. And it's a little different to be able to kind of like have everybody in front of you and be able to demonstrate things and so forth. So I'm really grateful for your being willing to be with us today, Melanie. And it's been going pretty well. We were talking just before we turned the recorder on about question asking, because students will often have some questions about this topic, especially when it comes to STIs and so forth. So you can either unmute yourself and ask Melanie a question, or if you're more comfortable asking it through the chat, please do. Nicole and I will periodically check the chat to see if there's any questions and let Melanie know. But if it's like one of those questions where she's talking about one topic and then shifting gears and your question hasn't been seen, please barge in and just unmute yourself and say, hey, before you go on, could I just ask? Because we want to make sure that the question gets asked as close in proximity to the topic that you're asking about as possible. Usually there's a number of questions that students have. STIs are relatively common among college student populations, as you guys probably know already, but as Melanie will talk more about today. And on the final exam, this is something we want to make sure you know a little bit about. And so historically, one of the essay questions in the final is for you to tell us a little bit what you learned about STIs. We ask you to talk about 4 different ones, whichever 4 you want to talk about, how you get them, how you know you got them, and what do you do if you got them. And that should become really clear from the presentation today as we talk about the different kinds of STIs that you can get. So we'll go for about an hour or so. Melanie will give you a short break, and then we'll pick back up again. We are recording today. And then in the second half of class, we have the motion picture Kids for you guys to watch as a way of kind of tying together sexuality through the lifespan, couple relationships, and STIs. It's really kind of a nice film that brings all of that together. So that'll be at 3:30, a little bit later today after the formal lecture part. All right, so we gave Melanie co-hosting privileges. Melanie's with the Tang Center. I mean, my fantasy is that you do a lot of this, Melody. It's like this is kind of like part of your gig, and so I personally learned a lot from you last year. I was really grateful that you came, and we're happy to be back again this year. So welcome.
Thank you. I'm really happy to be here. And yeah, I work at the Tang Center. I'm a nurse practitioner. I've been working here for about 6 years, but I've been a nurse practitioner working in kind of special interest in STIs and pregnancy prevention for over 24 years. So this is my bread and butter. The darker side of sex, the STIs we'll talk about first, and then we'll talk a little bit about birth control methods. And as Jamie said, I don't think with sharing the slide, I can't really see the chat. So please feel free to pipe up whenever you want to. It is a little different being on Zoom, but this is our world, so that's fine. So we're going to talk about a lot about STIs, sexually transmitted infections, how they're transmitted, who's at risk for which ones, what are the hot button issues with different STIs right now, and how do you prevent them. I want to talk about STI testing, what it is and what it isn't. We'll talk a little bit about consent for sex. I think you have a separate lecture on intimate partner violence and sexual assault, but there were just a couple things I wanted to talk about: healthy communication. And then we're going to talk about the birth control methods. And there is finally, after years, there's a new one on the market now. And we'll talk about some of the myths around them. So again, pipe up, this is for you, this is your lecture. So if you're not understanding something, or if you have other questions about things I'm not touching base on, I am very open to that. Okay, so sexually transmitted infections. These are infections simply passed by people, between people having sex, and it encompasses a whole lot of different kinds of sexual activity. And depending on which STI you're talking about, it can be transmitted either orally, anally, through genital, skin-to-skin contact. Some of them can be transmitted by exposure to fluids, semen or vaginal fluids. Others can get in the blood. And then some of these same infections can also be transmitted other ways. For example, hepatitis B by sharing needles, or from mother to baby during pregnancy. So again, you think about STIs, there are many different places, many different parts of the body that you're using for sex, and it depends on the different infection where we need to search for that and where you're at risk for that. We're kind of focused mostly on anal, genital, a little bit on oral sex. So general categories are bacteria, viruses, and then this kind of miscellaneous other category. And so for those of you maybe who aren't biology majors, remembering that a bacteria is just a microbe that is its own organism. So it is an entity unto itself. It can survive outside of a cell. So these are things like gonorrhea, chlamydia, and syphilis. Compare that to a virus, which isn't exactly a living body. What it does is it needs to kind of take over or engineer some of the cells in humans or whatever species they're infecting, and take over some of the DNA, RNA workings. They use other organisms to do their work, to reproduce. So these are things like HIV, herpes, human papillomavirus or HPV, hepatitis A, B, and C. Sometimes hepatitis C is sexually transmitted, sometimes hepatitis A is. And then there's probably what I would consider the most common STD that nobody's ever heard about, called molluscum contagiosum. It's a type of a pox virus, and it's pretty common in college age folks. It's not a dangerous thing, but it is contagious, kind of annoying, easy to treat. Then there are other things like one-celled protozoan called Trichomonas, scabies you may have heard about, that's a skin infection. And then there are pubic lice. However, I cannot remember the last time I've seen crabs. There is not a lot of pubic hair, so its ecosystem has really been devastated. So it doesn't really have anywhere to live, so we really don't see that much anymore. So finally, an STD that has decreased in numbers. Okay, and then this just kind of is a summary of how the different STDs are transmitted. So herpes and human papillomavirus, molluscum, lice and scabies, that's all skin-to-skin contact. And it needs to be genital skin to genital skin in general. There's a couple exceptions with herpes and HPV, and we'll talk about that. Syphilis, if there's an open sore, can also be transmitted. Secretions, you're talking about gonorrhea, chlamydia, trichomonas, and then as well as HIV. And then, of course, the bloodborne pathogens, HIV, hepatitis B, sometimes C. So gonorrhea, chlamydia, what this means is, and why it's important, is gonorrhea, chlamydia, they're in the secretions. They don't, for the most part, get into the bloodstream. And like trichomonas, lice, they don't transmit to other parts of the body via the bloodstream. Okay, so the state of STDs in the United States, and this is just from a couple of years ago, but what we're seeing is an alarming increase in cases of chlamydia, and that's very common in college age group, especially under the people under the age of 25. Significant increase in cases of gonorrhea, and we're seeing this especially in cis men who have sex with cis men. A lot of rectal, oral, urethral gonorrhea. And then syphilis. Syphilis is a really interesting case because we thought, when I started working with STDs specifically in 2000, we thought that we actually could eliminate syphilis. There was a program called the Syphilis Elimination Project. And as you're going to see in some of the slides, we are right back to where we started, in about like the 80s. We're really increasing the number of cases of syphilis. Again, gonorrhea and syphilis we're seeing in cis men who have sex with cis men. Okay, so let's start with chlamydia. So chlamydia is one of the most common STIs. It is the number one most common bacterial STI. And so it can infect the urethra. So think penis, cervix, so cis women, trans men, the rectum, and sometimes the throat. It doesn't do as well in the throat, so it's not something that we commonly screen for there. Chlamydia, it's a bacteria. What that means is it can be treated effectively with antibiotics, but it does have some, it's curable, but it does have some serious potential complications. And one of the primary ones of those is pelvic inflammatory disease, or PID. And this is where an infection that may start in the cervix goes up into the uterus and into the fallopian tubes and causes a major infection. PID could be potentially life-threatening. It needs a lot of antibiotics, and it also can lead to some serious consequences like infertility or chronic pelvic pain, or a higher risk for tubal pregnancy. So it's easy to treat with antibiotics, but one of the challenges with chlamydia is it's really common because hardly anybody gets any symptoms. So they just don't know that they have it. So for example, 90% of the people who have a cervix, cis women, trans men, 90% of those have zero symptoms. There's absolutely no clue that they may have this. So you don't think that you have an STI, and so it just continues to be spread. The highest risk is in people who are 25 and younger. And I'm going to show you some slides of the data, and there's some really significant racial disparities. So public health is about social justice, if any of you are studying public health. So again, some of the long-term complications are difficulty getting pregnant. This is mostly for people who have a cervix, chronic pelvic pain, tubal pregnancy, or pregnancy outside the uterus. The more times someone gets infected, the higher the risk for this. So the more times you get chlamydia, the higher the risk. So it's curable, but when you get it a second time, the way it just interacts with your body, it induces a really big immune response. So your body has this giant inflammation that it doesn't towards other types of bacteria. So the more you have it, the higher you're risking for some of the long-term complications. So it's treatable, but it's important not to get it repeatedly. And so this is what it looks like. So again, we see most of the cases in younger than 25 years of age. And I think that the total number on the curve is higher in female versus male. Mostly females get tested more than males do. They come in for a lot of different reasons to clinics and get more testing. This has been the shape of chlamydia for decades now. Okay, and this is what I wanted to talk about with the racial and ethnic disparities. You can see that among African American, both female and male population, there's 2 to 3 times as much compared to Caucasian. The reason for this is not clear. Some of it may have to do with social network, but I think that a lot of it has to do with, decreased access to health, because we see this in so many different diseases, and it's a horrible thing that we need to really figure out and address. I know you hear the numbers with COVID, with diabetes, with high blood pressure, and again, you see this with STIs as well. Okay, and this is what we're seeing with chlamydia. It just keeps going up and up and up. So it was first discovered, I think, in the 80s. And around the 90s, 95 to 2000, we thought the reason it was going up is because we had these new really fancy super sensitive tests. And we were just finding more. We were doing a good job testing more. And we thought that until 2000, 2005, and it just keeps going up. So it's a really difficult infection. I think that the plan of attack needs to be reassessed. Right now, our plan of attack is just screening and testing and treating, but I don't think that seems to be doing what we need it to do. So I think we need to come back together and come up with some other ideas. We need to think outside the box here. Okay, so chlamydia, it can infect the penis, the cervix, the rectum, sometimes the throat. Chlamydia does not get into the bloodstream. It can't spread that way, treatable with antibiotics. So then gonorrhea, okay, it is also a bacteria, and it can also infect the urethra, the cervix, the rectum, But gonorrhea is also very happy in the throat. So we see a lot of gonorrhea in the throat, primarily with cis men and cis men who have sex with cis men. It also can lead to pelvic inflammatory disease. In rare cases, it can disseminate. It can get into the bloodstream and cause infectious arthritis, swelling and pain in the knee, for example. It's not very common. I haven't seen this in years. Its highest risk populations are people who are 25 years and younger, and then again, cis men who have sex with cis men. There might not be any symptoms in people who have vaginas. More common in cis men to see symptoms. And again, with gonorrhea, there's even more racial disparities compared to chlamydia. Same long-term problems of infertility, chronic pelvic pain, and tubal pregnancy. Just looking in the chat, sorry. Okay, so the question is if there are some types of that are permanent and some that are very common. Oh, I know. How does anybody who's sexually active avoid these diseases? Protection's not effective for things like herpes. So we are going to talk about this. So so the short answer, I think we're going to talk about we are going to talk about the viruses in a little bit, and we can talk about ways to reduce or prevent infection with those. So not everything is curable, but the big STDs for the most part are manageable. So herpes, for example, can be managed with medication. HIV, I think we know now we have incredible antiviral medications that you can live a normal life. And so that you don't have the decreased life expectancy with HIV that we did in the 80s. One of the biggest problems with gonorrhea is antibiotic resistance. And I wanted to just talk about that a little bit. Okay, if I can, there we go. Okay, so again, it has the kind of the shape more in young people, but as we said, cis men, having sex with cis men increases the prevalence of gonorrhea overall. And then here you can see a more stark disparity among races, that African American have a much, much higher prevalence of gonorrhea. And again, public health needs to address, this is a social justice issue, I guess. So we as clinicians can't just be focused on the medicine. We need to think about, we need to be broader in our thinking and think about how to address this in a broader spectrum. Okay, so I wanted to show you what gonorrhea looked like over time. So in the 1940s is when we first started having antibiotics, so they had a big drop. And then huge increases when the sexual revolution came in the 60s, 70s, 90s, and of course, HIV epidemic here. And then we started to get a hold of it. So we did a lot of testing, we did a lot of treatment, but now we are on an upward turn with gonorrhea. And so we are just about where we were in the 80s. So while we had done a good job for a while, now it's coming back. I think that with the big scare of HIV, people were using and adopting a lot of safer sex practices that I think once we got a better handle on HIV, have then gone away. So we don't have, I don't think that there's as much, I think that we're not doing quite as consistent a job using condoms consistently. If you're using condoms consistently with gonorrhea, the risk is very, very low. Okay, so again, you can see this huge uptick. So we are pretty much at the prevalence and incidence of gonorrhea than we were in the 80s, so at our peak. So the big problem with gonorrhea is drug resistance. So, and this is a really smart bug because once it develops resistance to one antibiotic, it keeps that. So for example, it developed resistance to sulfa drugs in the 40s, and then in the 70s, it was resistant to sulfa and add penicillin. And then in the 80s, add tetracycline. In 2000s, we could no longer use fluoroquinolone. So where we are with gonorrhea treatment is there is only one type of drug that is currently available for this treatment. The only one that does the best job. It's called cephalosporins. Okay, so antibiotic resistance is probably something that you hear about in a lot of cases, not just in the STI or gonorrhea world. And the principal driver of that is, of course, what drives antibiotic resistance is the use of antibiotics. So the more we use them, the more we just kind of throw them onto symptoms that people have, the more bacteria get exposed to them and the more they can resist them. And so I say this specifically because gonorrhea has these kind of, we call commensal types of its genus. So there are related bugs in our mouth that just kind of live there all the time. And these Neisseria can share their properties with the Neisseria gonorrhea. And so azithromycin is a common antibiotic that's given for bronchitis. And this is why we have a lot of azithromycin-resistant gonorrhea. Just to emphasize, antibiotics are most often not needed for bronchitis, and so we really have to make sure that we're using them for the cases specifically that we need and not using antibiotics for viral illnesses. In case you were curious, what did we do before antibiotics? These are actual treatments. So pre-1937, treatment for gonorrhea was a 2-week urethral, so think in the penis, irrigation with silver, mercurochrome, which, mercury, or this other potassium permanganate. This would, of course, maybe treat the gonorrhea, but it also leads to incredible pain and scarring. And then another pre-antibiotic treatment was a literal red hot poker. So horrible things that we don't want to have to go back to. Okay, so when you study STIs, your friends and family, every time they come across something, a sign or article on STIs, they think of you. So my friend found this and he thought of me. I always thought, what is the do not attempt self-treatment? I didn't know what they were worried about there. Because we talked about gonorrhea, chlamydia, those are primarily transmitted from fluids. Now we have syphilis. And so this is more like skin-to-skin contact. It is a bacteria. It's called a spirochete. And it's very treatable with penicillin. So unlike gonorrhea, where we have to keep finding new treatments, syphilis is not resistant at all to penicillin. It's been the same drug for a century. It can, however, lead to very significant illness. In about a quarter of the population, if left untreated, it can cause serious brain damage, skin problems, damage to the heart. So it is potentially life-threatening. The testing is a little complicated, so we don't have a simple PCR test that we do for gonorrhea and chlamydia. And as I said, we felt like we were almost at the point where we could eliminate syphilis in the United States. I think the numbers were about 4,000 cases in 2000, and now we're right back up into 50,000 cases. It's an incredible, over tenfold increase. Primarily, we see this in cis men who have sex with cis men, Latinas in California, and then certain pockets around the United States. One of the big concerns with syphilis is congenital syphilis. So syphilis passes easily through the placenta and can cause a devastating, life-threatening illness to a baby. So this is a completely preventable illness, congenital syphilis. And yet California has some of the highest rates. They have the highest rates, I guess I'd say, in the United States. So you can see, before we really got a big handle on antibiotics use in the 40s, a huge decrease, and it stayed down until the 2000s started to come up again. So something that's completely treatable. And for the most part, with condoms do a great job of reducing the risk of syphilis, not to the same extent as it does for HIV, gonorrhea, and chlamydia, but that definitely does a really good job. Okay. And you can see California kind of leading the curve here compared to the rest of the US in primary and secondary cases of syphilis. And again, this one is the one that really shows it. We had done a good job of decreasing it, and now we're right back to where we were in the 1980s. Okay. All right. And again, syphilis is also highly associated with HIV. So cis men who have sex with cis men have the highest proportion of syphilis, and it's closely associated with HIV. Okay, so those are the primary bacterial STIs, and now let's talk about the viruses. And so the most common sexually transmitted viral infections are herpes and human papillomavirus. So the way you get herpes is there can be like a little microscopic cut in one's skin. And so one person has herpes on their skin, and then they're having close contact with somebody who has a little cut on their skin, and the virus breaks through the skin. So again, this is very close contact. So herpes type 2, which is a genital infection, it needs to be genital contact. So it enters the body and it goes along a nerve root, and it sets up shop. It lives in your spinal cord. This is why it's a permanent infection. We don't have a way yet, we don't have a treatment yet that can access the dorsal horn where this lives. We don't have, the immune system just can't really access it there. So it lives there. So it comes along the nerve roots and it lives in the spine. So for genital herpes, it's the lower back spine. And then for oral herpes, in the spine of the neck. And then from time to time, the virus then goes back down the nerve roots to the skin. And sometimes when it does that, there's absolutely no reaction. And so you can be infectious without knowing it. Other times when it comes back down to the skin, it will cause a blister. If you've ever seen a cold sore on anybody with a cold sore, that's herpes type 1. Okay? So it's permanent because your immune system can't access it. And from time to time, it comes back down the nerve roots to your skin to cause painful sores, or it can just be there with absolutely no symptoms. Yes, so the question is there a difference in your risk of transmission if there's an outbreak or not? So if somebody actually has an open sore, an active sore, a wet sore, there's a lot of herpes virus there. So it's very easy to transmit that way. It's not as easy to transmit if the herpes virus is just on the skin. However, what happens with herpes is that you never know when it's on the skin. So there are going to be a certain number of days when somebody's infectious and there's just not a way to know that. There is a way to manage that. So I don't want to make people feel hopeless. Okay, so this is caused by a virus, and there are two types related to sexually transmitted infection. There's herpes type 1, and that is just as happy in the oral area as the genital area. And then there's herpes type 2, which is more classically called the genital infection. For some reason, that virus, its character is it just doesn't like the mouth. And so it's you don't really get herpes type 2 infections in the oral area. So it's not curable. We can't get it out of your body, but it's very manageable and it's very common. So 1 out of 7 people in the United States has genital herpes. So next time you're in a big crowd, you can just kind of count 1, 2, 3, 4, 5, 6, 7, and you'll just see like there's a lot of people. And only 1 out of 5 of those people will have classic symptoms. So if you have 5 people with herpes, 1 person has the classic symptoms. So they're like, you know what, I bet this is herpes. 3 people will have some symptoms that kind of like, maybe this is herpes, I'm having this kind of recurring irritation in the genital area. And then there's 1 person out of that 5 that has herpes that has 0 symptoms at all. So this is a recurring infection. The longer you have it, the fewer outbreaks you get. There is what I call asymptomatic shedding, where you have the virus on your skin, but you don't have any symptoms. But it's very treatable. First of all, it's very common. An initial or a first outbreak, you may have multiple really painful sores. It can be a really painful experience the first time you have it. Subsequent outbreaks are usually usually just one sore in the area. So they're a lot milder. And herpes type 1 is a lot milder, fewer recurrences than herpes type 2. So they can be treated. So you can take medication as soon as you notice an outbreak, and that speeds the healing. If you do nothing, these things are going to heal up. But if you can take medication to speed the healing. And if you either have frequent outbreaks or you have a sexual partner who doesn't have herpes, you can take medication daily. And that's called suppressive therapy. And that really reduces the risk of infection to another partner. It reduces the number of frequencies, of outbreaks significantly. So what I mean is manageable. So herpes causes painful sores. Recurrences are usually really mild. And in general, there aren't any severe outcomes or consequences from herpes. It's usually just, I'd call it obnoxious, not dangerous. There are some complications, but these are really uncommon. So I think the big news with herpes is herpes type 1. So the prevalence is really high. A lot of herpes type 1 compared to herpes type 2, and that's because a lot of people have cold sores, so we see that a lot. And of course, the risk of both of those increase with age, because once you have it, you've got it. So the more people, the numbers just keep going up as age goes up. Women or people with vaginas are much more vulnerable to both types of herpes 1 and 2, just because of the character of the mucosa, the skin in the genital area of people with vaginas versus a penis. So much higher incidence in people with vagina versus people with a penis. The prevalence of both of these has decreased over time. So that's some good news in the STI world. I thought I saw another question. Oh, is it beneficial to avoid herpes type 1? So this goes back to the question of what do we do about this? I mean, it kind of makes you I don't want to have sex at all. And I'm not sure exactly how to answer that question. There are definitely things that you can do to decrease your risk of getting herpes. I can say that also because, in your age group, you're much less likely to have had oral herpes compared to my generation. Probably half of the people my age will have oral herpes because our parents weren't careful about spreading it, getting kissed by an aunt who has a cold sore when we were babies. And we did a better job with your generation. One of the consequences of that, however, is that now your generation is more vulnerable to getting genital HSV1, and we'll talk about that. So again, significant racial disparities here. And then you can see the prevalence of women, females compared to males here. So very, very common, obnoxious, not dangerous. Okay, so one of the big things that we see, especially at the Ting Center, is that since fewer of you all get oral herpes in childhood, you don't have any protection against getting HSV1 genitally. And so that's where we're seeing a lot of this. So in one study, it was a vaccine study, but they found that 60% of the genital herpes that they were seeing was from herpes type 1. And then in a study of college students, the proportion of genital herpes resulting from 1 compared to 2 is increased 78%. Herpes type 1 and 2 act the same way. I would just say that herpes type 1 is kind of like the milder case of it. Has fewer outbreaks. Some people get one outbreak and then they never notice it again. So it's more likely not to be a problem. If you have herpes type 1, you are still vulnerable to getting the other type, unfortunately. So herpes type 1, mild, obnoxious, not dangerous, but we're really seeing this in your age population. And I think that the best that we can do is avoid sex when somebody has a sore. I imagine you all are doing that. And know that condoms definitely help reduce the risk. And I think I have some slides on that, but I'll just say that using a condom with sex reduces the risk of genital herpes by about half. So you can reduce your risk significantly by using condoms, and also by taking suppressive therapy. Taking daily suppressive therapy also reduces your risk by half. So this is what I mean about the prevalence of herpes type 1 by age. So people my age, it's more than 50% of us are going to have herpes type 1, most likely oral. I think one of the challenges with herpes in the patients that I see is that there's this really unfortunate stigma associated with it. You have a sore in the bathing suit area, and so it comes with all of this shame. And so one of my life's missions is to really fight against that shame. There's no shame, no blame. This is something that people get. It's just in a private area. It's not the end of the world. People have to go through a process to, kind of adjust to the diagnosis, but very manageable, not life-ending. So when we talk about STIs, one of the things that people want to know is, well, why don't we just test everybody for herpes? And a lot of people have gone through regular STI testing and kind of assumed that they've already been tested, when in fact we rarely test for herpes, and this is why. So if you have an active sore, there's one type of test, a DNA test. We can do a swab. That's an excellent test. It's very sensitive and very specific. But if you don't have a sore, you're not having any symptoms, you just kind of want to know if you have it or not, that means that we need to do a blood test. And those tests are not that great. So they're not as sensitive. They're not that specific. So that we don't recommend routine testing if you're very low risk for that, because then if you get tested, you're low risk and the tests aren't very great. A positive test is about 50% likely that it would be a true positive. So is it a true infection or a false positive? So it's a 50-50 chance. If you really don't have a specific risk for herpes, if we test you, your test is an actual positive. So not that great. And we don't have a way to confirm this test. So people who get tested for herpes are people maybe who have a partner who has herpes or have had some symptoms that seem like herpes. Those are the folks that are better to test. So again, just to say, herpes, it's a virus, not a judgment. And there we go. Okay, sorry. I think, yeah, okay, sorry about that. Then, just thought I could just I'm not sure if I can get this to play. Nope, sorry, that was a good one. All right, so let me I want to do a quick time check. Okay.
Well, is there anything I can do to help from my end?
No, that's okay. I'm just, I didn't want to, I swore I uploaded it right and I thought it was going to play. I tested it. I'll see, I'll try at the break to see if I can get it working.
And
So
are you seeing the questions as they pop up, the chat questions as they pop up?
um, I am checking periodically.
Okay, good.
So I've been
Because it
checking.
looks like it's just the two so far.
Yeah,
Okay,
yeah.
good. All right.
Okay. So just go. Sorry for the strobe-like feature. Okay, human papillomavirus or HPV. So just the basics about it. One of my friends who works at the STD control branch calls this the common cold of the STD world. So really common. There are over 40 different strains that can infect the genital area. Most people will get exposed to these at some point in your life. They're that ubiquitous. But the good news is most people who get it will clear it with time and suffer no problems. So 80% of people are going to get exposed. Most people are going to clear it. But it can lead to some problems down the road. So it can lead to genital warts. It can also lead to certain types of cancers in the cervix, vagina, vulva, the anus, and throat cancer. The vaccine is one of the best tools that we have to fight HPV. So the vaccine that is offered currently will protect you from the 9 most prevalent strains of HPV. And there's incredible data showing how effective the vaccine is. In Australia, where they have, I think, mandated HPV as part of their vaccination program, and they also have a lot of data from their national databases, they have almost virtually eliminated genital warts. So this is something that that we can actually win, if we do really widespread vaccinations. And so everybody should know their status if they've been vaccinated or not, and know that insurance should cover vaccinations under the Affordable Care Act. So this is a really important one to get. A lot of people have questions about oral sex and STIs, so I just wanted to talk about that a little bit. Kind of one of my professors used to call this GWIS science, meaning, they actually do studies. Yes, most people have had oral sex. I think we probably knew that without having to study it, but it's always good to have the data. So most people have oral sex, but nobody uses condoms. So the percent of adolescents who report using condoms with oral sex is less than 10%. I'd say it's pretty close to zero, and not just for adolescents, for all people. I get it, and I feel a little sheepish recommending it. I think one day we'll have a condom that people may seek out, or we'll have some better way of preventing STIs, but this is what we have right now. Actually, the Gates Foundation is doing research and trying to find a condom that enhances sex and makes sex more pleasurable. One day. So oral sex, what can you get from oral sex? You can get gonorrhea pretty easily, but more from a blowjob than giving oral sex to a woman. Chlamydia doesn't like the throat as well. And most of these infections are asymptomatic. So most people don't notice these throat infections. With human papillomavirus or HPV, most of the infections with HPV are genital. There's a 5 times less prevalence of HPV in the mouth. And so it's something that still is being studied furiously. But there are other factors, I think, that make it easier to get HPV in the throat. Smoking is one of the cofactors, alcohol another. So the more smoking, the more alcohol one drinks, the more they would be at risk. And again, men more than women. Okay, okay. So what do we do to prevent STIs? Because again, if you are just thinking on the face of it, you could get overwhelmed. It's like, I don't even want to leave my house. I'm so worried about this, but there is a lot that you can do. Condoms do a fantastic job. They are just about as close to 100% effective against HIV as you can get. They do a really good job preventing gonorrhea and chlamydia, and they do have some effectiveness against human papillomavirus, HPV, herpes, and also syphilis. So they are worth using. Vaccination, make sure you get HPV vaccine and also hepatitis B, hepatitis A. Talk to partners, talk to partners about what their history is, and just how you want to have, what kind of things that you want to do to have safer sex. If somebody knows that they have herpes, they may want to go on daily suppressive therapy. That reduces their risk of transmitting to a partner by half. But if both partners have herpes, there is no risk. You can't get herpes more if you have the same strain. So I think that there is a lot to do. I think that there isn't a way to just test one's way out of it, to go in, get an STD test, a panel, and then know that they're what they call clean. These are just infections like all of the viruses that are in the environment right now. We're dealing with COVID. How do we prevent that? I think that there are different solutions for different infections. Okay, so vaccines, talk to your partner, condoms. There are also internal condoms that can be used for anal sex, and the internal condom can go in the rectum or the vagina. Dental dams. There are different kinds of sexual activity that you can have. Mutual masturbation, kissing is less risky than anal sex, for example. There's suppressive therapy for herpes. And then one thing we haven't talked about is PrEP for HIV. So so for PrEP, there's a medication now, a pill, the brand name is called Truvada, that if you take this pill every day, it reduces your risk of getting HIV by like 99%. It's amazingly effective. And so for folks who are higher risk for getting HIV, cis men who are having sex with cis men, sex workers, taking PrEP on a daily basis, which should be covered by insurance, is an incredible way to prevent HIV. So I think this is just revolutionary, having this capacity. There's also what we call PEP. So PrEP is pre-exposure. So taking a medication before you get exposed to HIV. There's also PEP, which means that if you have sex with somebody and after that exposure, you can take a medication to help reduce your risk. We often will use that in the cases of sexual assault. So there is a lot to do to prevent HIV. Okay, to crash test dummies. Was it safe for you? What does it mean, safer sex? This is constantly evolving. So again, I just want to say a lot of people will come in and just want to be screened for all STDs, and we just don't have a way to do that. We screen for infections that may not become obvious. For example, chlamydia, it's a good one to screen for. People don't know they have it. If there's a high prevalence, if it has serious health consequences, we do, if it's a cost effective, it's going to make a difference. And then there are other reasons they decide to screen everybody for something. For herpes, we don't have great tests for screening, and we don't have those for HPV either. There's absolutely no commercially available test for testing for men. So when you all go in and you get routine testing, mostly you're getting gonorrhea and chlamydia test, and you're getting tested at the sites, the body parts that you're using for sex, so vagina, rectum, or throat, HIV and syphilis. So chlamydia, gonorrhea, HIV, and syphilis are what we do routinely. For cis men who have sex with cis men, we add hepatitis C testing, hepatitis A, and hepatitis B. Those are much lower risk in heterosexual populations. Okay, so we don't routinely test for herpes and for HPV. So we can't just test our way out of things. We can't just go in, get some tests, and feel fine about it. So we need to expand our thinking, encourage and support conversations with partners, promote healthy sexuality. So safer sex isn't necessarily disease-free, but it really should be stigma-free, and people should be informed. I gave you some resources here. The CDC is a great place. I think when you're going to get information on this, I like to recommend pointing you in the direction of really reliable sources, the CDC. And then there's also one called ASHA, American Sexual Health Association, sexualhealth.org. Okay, so sorry, it's hard for me to see where the time is. Is it about an hour? Are we at about an hour, Jamie? So we could take a break here. Okay.
Yeah, I think so. I mean, I think this would
Okay.
be a good place. I mean, it's a natural breaking point for you, yeah?
Okay, great. I'm going to run and get my phone so I can see the clock better, and then I'll be back if people, so we can take a break here. You can organize that how you want. And if people
how about if we take about 10 minutes?
I'll be here.
Does that sound okay to everybody? So it's 2:25, so maybe
Okay.
at 2:35, if that's okay.
Okay, great.
Okay, we'll see you guys back at 2:35.
Thanks. Okay.
Okay, so it looks like just about everybody's back, and I think Melanie's on her way back too. And we'll have Melanie with us for another hour. So if you guys have questions that you haven't asked yet, make sure you get a chance to ask them during the second part of the presentation. And we've got some new material coming up also on safer sex and on pregnancy prevention. So we're going to shift gears a little bit, I think, right now. So are you back with us, Melanie?
Yeah, I'm here. I don't know. It says that I cannot start my video. You cannot start your video because the host has stopped it.
Okay. Are you here, Nicole?
I'm sorry?
Are you here with us? Okay.
Cool. Yeah.
So do you need to do something on your end, maybe?
There we go.
Okay.
There we go.
Is
that it? Okay.
Okay. Yep. I think we're on.
Okay.
And are we recording?
Yeah. I heard that it said it was. So.
Okay. All right. Part 2.
So that was all heavy. So I just thought we could do something a little humorous. So let me see if I can get this to play. I always like this STD humor.
I don't think is there a video?
Oh, you can see it?
No, we're still looking at the slides. I think we'll have to share a different video.
Okay, of course. Sorry.
I run into this. I run into this sometimes too. I think you have to stop sharing.
Stop
and then go to the.
And then start again.
Yeah.
Sorry, folks. Thought it was going to be just so much easier.
No, it took me a class
share, and then here we go. Okay. There we go. Now you can see it?
Yep.
Okay.
Now, this, did you enable the sound?
There we go. Can you hear it?
No, we can't hear it. So you may have to stop sharing again.
Yeah, I don't know that it's worth it. It's not that funny.
But like if you stop sharing and then you go to share again, there's a little box at the bottom that says share my sound or something like that. So you just have to click that box.
Okay, got it. Okay.
And then we'll be able to, yeah, no, I've been there already. I've had this happen in both my classes.
Okay, let's try one more time. If it doesn't work, then we're done.
Okay. We're good. We're good.
Right.
The word is gonorrhea.
Could I have the definition, please?
Gonorrhea is one of the most common sexually transmitted infections among 15 to 24-year-olds. In fact, about half the people who have gonorrhea don't even know they have it.
Could I have it in a sentence, please?
When Tommy had sex with Jane without using a condom, he ended up getting gonorrhea.
Gonorrhea. Gonnorea.
The word is human papilloma virus.
I liked it. Can you see this one? Because I did want to play this one.
Yeah, we can see it.
Okay. All right. So then we're going to talk just a little bit about and then
Abstinence.
If you're still struggling,
Definition.
I'm so sorry.
Abstinence means self-restraint
Close that.
or self-denial with regard to.
Okay. Can you see the consent? Or do I need
Yep,
to stop?
we can see
Consent
it.
is, the consent is queued up now, yeah. So we can see that, and
All right.
hopefully we'll go with it.
Sorry, folks.
if you're still struggling with consent, just imagine instead of initiating sex, you're making them a cup of tea. You say, "Hey, would you like a cup of tea?" And they go, "Oh my God, fuck yes, I would fucking love a cup of tea. Thank you." Then you know they want a cup of tea. If you say, "Hey, would you like a cup of tea?" And they're like, I'm not really sure. Then you could make them a cup of tea or not, but be aware they might not drink it. And if they don't drink it, then, and this is the important part, don't make them drink it. Just because you made it doesn't mean you are entitled to watch them drink it. And if they say no thank you, then don't make them tea at all. Just don't make them tea. Don't make them drink tea. Don't get annoyed at them for not wanting tea. They just don't want tea, okay? They might say, "Yes, please. That's kind of you." And then when the tea arrives, they actually don't want the tea at all. Sure, that's kind of annoying as you've gone to all the effort of making the tea, but they remain under no obligation to drink the tea. They did want tea, now they don't. Some people change their mind in the time that it takes to boil the kettle, brew the tea, and add the milk. And it's okay for people to change their mind. And you are still not entitled to watch them drink it. And if they're unconscious, don't make them tea. Unconscious people don't want tea. And they can't answer the question, "Do you want tea?" Because they're unconscious. Okay, maybe they were conscious when you asked them if they wanted tea. And they said yes. But in the time it took you to boil the kettle, brew the tea, and add the milk, they are now unconscious. You should just put the tea down. Make sure the unconscious person is safe. And this is the important part again. Don't make them drink the tea. They said yes then, sure, but unconscious people don't want tea. If someone said yes to tea, started drinking it, and then passed out before they'd finished it, don't keep on pouring it down their throat. Take the tea away. Make sure they're safe, because unconscious people don't want tea. Trust me on this. If someone said yes to tea around your house last Saturday, that doesn't mean they want you to make them tea all the time. They don't want you to come around to their place unexpectedly and make them tea and force them to drink it going, "But you wanted tea last week." Or to wake up to find you pouring tea down their throat going, "But you wanted tea last night." If you can understand how completely ludicrous it is to force people to have tea when they don't want tea, and you're able to understand when people don't want tea, then how hard is it to understand it when it comes to sex? Whether it's tea or sex, consent is everything. And on that note, I'm going to go make myself a cup of tea.
Okay. Sorry, I didn't get the PG rated version of that. Okay, so let me just share my screen again. Now we're back. Okay. So, I don't know, 20 years or so ago, the big campaign said no means no. If they say no, you don't want to have sex, that means no. But the next evolution of that is now yes means yes. And so now what people are talking about in sexual health is an affirmative consent, not that you don't have to guess. Like, do you want to have sex? Yes, I want to have sex. So it's voluntary, mutual, and can be withdrawn at any time. And just like the video said, past consent doesn't mean current or future consent, no consent where there is force, intimidation, or coercion, and no consent if somebody's incapacitated or impaired. So this is what it can look like, communicating when you want to change, asking, is this okay? I'm open to trying this, yes. Other physical cues. It doesn't look like refusing to acknowledge a no, assuming that wearing certain clothes, flirting, kissing, I think this is not news to you, someone being incapacitated or pressuring, assuming that you have permission because you've done it before. So again, the video. There's a nice TED Talk on promoting healthy sexual behaviors, finding a better metaphor. So Al Vernacchio is a teacher, I think in the San Diego area, and he talks about how kind of the damage of the current sexual metaphors around baseball are, and how we really should, in order, if we want to promote healthy sex, to adapt a more healthy metaphor, although I'm not sure pizza is the way to do it. But in baseball, we talk about getting to certain bases, and you do it in certain order, and there's rules to it, and there's winners and there's losers. Whereas pizza, no winners or losing. Everybody has to talk about it at the beginning, talk about sex, what you want to have. If you wanted pizza last night, doesn't mean you want pizza now. Everybody has to agree on the toppings, things like that. So I won't take your time up with it, but I will encourage you to take a look at the TED Talk. So it's For Goodness Sex, changing the way we talk about sex. I think it's worth a look. So I'm just going to wrap up here by talking about birth control methods. We have a lot of choices these days. Now, there have been different birth control methods, since ancient Egyptian times and probably before. Some kind of more bizarre ones are using crocodile dung. And they're all different kinds of versions of condoms made of papyrus or cow intestines. There's some that actually had some, biologic plausibility, using a date and honey pessary. And that's a pessary is something that you would insert into the vagina. The kind of stickiness and the acidity of the acacia are kind of a little bit of a spermicide. So it was just kind of an interesting thing. And one of the most interesting things I found when I was looking into the history of contraception is that until about the 1950s, the most common method of birth control was douching. And you're thinking douching, which is kind of squirting a fluid into the vagina to clean out the sperm. You're thinking, I've never heard of that as a method. And that's right, because it really doesn't work. But that just shows you kind of the state of things before we got to the birth control pill. There were condoms, but important to know that really, I think it was 1973, some methods of birth control were illegal. They were considered a type of pornography. And so they weren't legal. And I think the last one was the last law on the books was in Connecticut, and it finally was taken off in the 1970s. So in the late 19th and early 20th century, there were douching, condoms, withdrawal, fertility awareness, and condoms, or IUDs. And I wanted to show you this block pessary on the bottom. The American College of Obstetricians and Gynecologists actually had it recalled. It was considered a torture device because that's a piece of wood and it has a concavity taken on each side. The idea was that no matter how it sat in the vagina, it was used in the vagina, it would cover the cervix. So you can imagine how painful that was. And things weren't even any better when you go to the doctor. You can look at these things that were inserted into the cervix. really scary looking things that could result in infection and lacerations. But to the modern day, oh, and just a quick thing, we're talking about douches, and then just kind of a quick, did you know that when magazines talked about douching and feminine hygiene, the word or the term feminine hygiene was actually kind of a dog whistle for contraception. So Lysol was a common product that was used for douching, meaning for birth control, back in the day in the 1940s. Okay, so modern day. So there's a high level of need for birth control. So on average, in the United States, people want 2 children. And so conceiving, giving birth to 2 children, that's going to take about 5 years, preparation, pregnancy, postpartum. So that is going to leave about 30 years of reproductive life that somebody's going to need to use a birth control method. So we really want something that somebody feels comfortable with and that is easy and has all of the characteristics that they're looking for. So 43 million women of reproductive age, and 7 in 10 are sexually active and don't want to become pregnant. And using any method reduces a couple's chance of having an unintended pregnancy. So even the methods that we think of as less effective, they're still methods. And for the past 5 decades or so, the unintended pregnancy rate has not changed. So about half of the pregnancies in the United States are unintended. 1 to 5 of these is among adolescents. Now, not all of these are unwanted pregnancies, but still we should be able to do better than that. Half of the unintended pregnancies result because somebody just wasn't using any method of birth control. Like I said, any method of birth control is going to reduce the risk. Just very quickly, just a reminder of what the menstrual cycle is. The most fertile time, the highest risk time to have sex, is the several days before ovulation, before the egg is released from the ovary. That's because sperm live in the reproductive system, up to 4 or 5 days. So this is the time that somebody is most fertile. After ovulation, fertility goes way down. So the hormonal birth control methods, they all kind of work on the same principle. They use a synthetic version of your own body's progesterone to prevent ovulation. That's the main way that they work. So the hormones give feedback to the pituitary to stop ovulation. There are other ways that they work, but that's one of the mainstays. They also thicken the cervical mucus. So down here, let's orient it. So the cervix down here at the bottom, progesterone makes a really thick plug. Sperm cannot penetrate through that, and also kind of thins the uterine endometrial lining. So some hormonal methods of birth control stop ovulation. I'll show you which ones. Others work primarily by thickening the cervical mucus. So the way we talk about birth control methods is in tiers. So the top tier, top shelf, top line, first line are the long-acting methods like IUDs and the implant. So there's an implant and then IUDs that can be put in place. These have high satisfaction rates. They are a put it in and forget it method. So fewer than one person will get pregnant over the course of a year if they're using the long-acting methods. The next tier, they're good, but they're less effective because they need help in working. So you have to remember to use them. So then you have the pill, the patch, the ring, and the shot. And then the lowest tier are things like fertility awareness or condoms, either internal or on the penis, and withdrawal. Withdrawal is a method that you always have access to. And so these are less effective, but they're very easily available. So why is that? When we talk about effectiveness of a birth control method, there are 2 measures. So one is, what is its potential? What is, if it were used perfectly, how well would it work? And you can see, like even looking at withdrawal, it's not bad. 95% of the time it's going to work. But the problem is that there's a difference between perfect use and typical use. So perfect use, what is its capability? What's its best shot if it's used absolutely perfectly? And then typical use, if we look at 100 couples over the course of a year, what's typical use? And so you can see the wider the bars for the methods that need more attention. So withdrawal and condoms, they need to be used every single time. And there's attention that needs to be paid to them. And then you have what it says CHC, that's birth control pills, the patch and the ring, still relatively wide. So if it's used absolutely perfectly, the pill is about 99% effective. But if you look at 100 normal human beings, it's about 92% effective. Same with a shot. But the long-acting methods, the IUDs and the implant, because they don't need any assistance in working, perfect and typical use the same. So they're all over 99% effective. So they are the most effective methods that we have. They do the best job.
We had a question that came in.
Oh, sure.
It's just students said, I've heard stories of women that experience pain from the IUD. How likely is that?
Yeah, so we'll talk about the IUD specifically. So I'm going to run through that. So thanks for that question. I'll make sure I talk about it. Okay. And then there's pain from the IUD itself, and then pain from the placement process. Another thing that's important to know when we talk about, well, the pill patch ring, 92% typical effect, 92% effectiveness, typical use. Well, that's not that bad. But you see that increases over time. So if somebody's using a pill, there's a cumulative effect. So there's more risk of failure over time, just because of the way the statistics work out. Okay, frozen, there we go. Okay, so these are some of the common myths that we hear. So everybody, if you ask, they know that birth control pills cause weight. Well, what's the truth about that? The truth is that when they control for other factors in really tightly placebo-controlled studies, they don't see any association of weight gain specific to the birth control pills. And they've done very good randomized control studies in this, in primates as well. So what is true is that people tend to gain weight over time, but there are other factors that can be associated. Sometimes when a person is on birth control pills, that means that they may be starting a relationship. People in a relationship tend to gain weight over time, but birth control pills themselves haven't been seen to cause weight gain any more than a condom does. Some people are worried about birth control pills causing breast cancer, and the birth control pill hit the market over 60 years ago. And so they have a lot of data, and they have seen that there really is no difference in breast cancer risk if you've ever used the pill or if you've never have. If you have cancer, the birth control pill is a really bad choice for you because it's like fertilizer for cancer, but it doesn't cause cancer. Some people have heard that IUDs really should only be used if you've already delivered a baby. So people who've never had kids feel like they shouldn't have the IUD. I think this thinking is falling a little bit by the wayside. But that's also false. People who've never been pregnant can absolutely get an IUD. We place them all the time. Some people were thinking that it would be easier for the IUD to fall out or higher risks of pelvic inflammatory disease in people who never were pregnant, but that is absolutely not true. Some people wonder if the birth control pill can actually reduce types of cancer, and this is true. So the lifetime risk of ovarian cancer is reduced 40% in people who've used birth control pills. And this is probably true of the patch, the ring, the depot shot, any of the methods that stop you from ovulating. It also reduces the risk of cancer of the uterus. So some people have a family history of ovarian cancer. Birth control pills are one way to help reduce that risk. People probably know this. Birth control pills can help improve acne. This is true. Any birth control pill that has estrogen, so almost all of them can help with acne. But there were ones that actually went through the studies. I don't know if in real fact these are better than others, but we often start them on a generic equivalent of these. Some people worry that or feel that they maybe need to take a break, that they take the pill and they need to take a break, or it may be harder, the longer they use it, it may be harder to have children later. And that is also absolutely false. Again, we have over 60 years, 80 years of data now on the birth control pill, and there's absolutely zero impact on future fertility. What does cause infertility, or what does make it harder to get pregnant, is chlamydia. And so the birth control pill won't, but you really should use condoms to prevent chlamydia, because that is one of the most common ways that causes of infertility. So let's take a closer look at some of the methods. So these are two types of, or different types of IUDs. So there are IUDs that have hormone. Here on the left, there are 3 different hormonal IUDs. On the far right is the copper IUD. And then we have an implant, which goes under the skin in your arm. So let's see. Yeah, so, okay. So the implant goes on the left, that goes under the skin in the arm, and it could last for up to 3 years. It releases a very low dose of a hormone like your body's progesterone, and it works by stopping you from ovulating. So it's a very minor procedure to have it put under the skin. We numb up the arm and give it to you like a shot. So very easy, wrap you up and you're ready to go. And it can last up to 3 to 5 years. And so very effective, very high satisfaction rate. And then on the right, you see the IUD, so intrauterine device. It's placed into the uterus directly. So it is uncomfortable having it put into place. I would compare it to like a heavy menstrual cramp, but I would also call it breathe-throughable. Y'all Berkeley students have grit. This is not going to be the hardest thing you've ever done. And the procedure itself just takes about a minute. Some people have a harder time than others, but I can say that I pre-COVID was placing at least 2 of these a day, and we have other providers, so we were placing about 10 a day. We place over 500 a year. So it's uncomfortable having it placed. That's true. And then once it's in place, there was a question about, well, I hear that they cause pain. That's mostly associated with, so first of all, if you have a hormonal IUD and you're having pain, you should get it checked out to make sure that it's in place. The copper IUD, the non-hormonal version of the IUD, is the one that frequently will make your periods heavier and crampier. And so that is true. So people who have easy periods, I think, are good candidates for the copper IUD. But if anybody is kind of miserable during their period or has cramps or heavy periods, I wouldn't recommend that one for them. So most people do fine. So the implant works by inhibiting fertilization. I mean, they all work by stopping an egg from eating sperm. The implant works by stopping you from ovulating. The hormonal IUDs, the Mirena, the Skyla, the Kylena, they work primarily by thickening cervical mucus. They also interfere with sperm motility. The copper IUD, the main way that it works is it releases copper into the uterine cavity, and it interferes with the sperm. It's a very fancy, very effective spermicide. So these have the highest effectiveness rates, so that's the good news. They're long-acting, so they're kind of liberating. You are not tied to thinking about your birth control method every single day. For the hormonal methods, there's less bleeding and less cramping. Potential downside is, for the copper IUD, heavier, crampier periods. For the hormonal IUDs, you may have some unscheduled bleeding at the beginning. And with the implant, you will have unscheduled bleeding, but it's usually lighter and less. So people who aren't thinking about getting pregnant in the next year, or don't want to take a pill or have a hard time taking a pill, these are good candidates. The next methods are the pill, the patch, and the ring. And then I wanted to show you, so the black box here with the hand holding a ring, this is a brand new method. It's called anovera. And this is that one ring can last somebody an entire year. So the vaginal ring, which is the second picture here, is a ring that's placed into the vagina for 3 weeks. It's taken out for a week. And so in for 3 weeks, and then you go ring-free for a week. So it's on a 28-day cycle. This new ring, it is on that same cycle, but you keep reusing it. So you put it in for 3 weeks, take it out for a week, clean it, put it back in for 3 weeks, take it out for a week, and you can do that for a year. So that's one of the kind of new inventions that we have in birth control. These other methods, the pill, the patch, vaginal ring, so they all work the same way. They give you hormones for 3 weeks. We take the hormone away, you bleed, but it stops you from ovulating. It's the main way. So the pill is something that you take daily. So 1 pill every day, about the same time every day. The patch is a weekly method. So you're switching patch every week. And then the vaginal ring is a monthly method, or this one that's reusable, good for a year. I haven't had people on that, but I think that's coming. And then there's also a shot that is good for 3 months. I think that's fallen out of favor now that we have the implant, because the implant is a much, much lower dose of hormone, and it's good for 3 years instead of 3 months. So these also stop you from ovulating. They're highly effective if you use them right. Any hormonal method is going to lighten your bleeding. These will give you very predictable bleeding. The ones with estrogen are going to help with acne. Some people are bothered by what I'd call nuisance type side effects with these. So you may have like some nausea or bloating, or you may have some mood changes. Most people do just fine, but some people do have bad reactions. And then not everybody is eligible for the pill, patch, or ring. If somebody has a certain type of migraine, it's called migraine with aura or high blood pressure, not everybody is safe to take these. Okay, and then the third tier down, the barrier methods. You're all familiar with condoms. There are also spermicides, which are less effective than condoms. Spermicides come as a gel, a foam, a dissolvable film. On the top left, you see a cervical cap. These are given, have to be fitted. And I have not had anybody ask for that, but Planned Parenthood still offers them. There's an internal condom. We used to call it the female condom, on the bottom left. And then one of the newer methods in the past few years is this purple dome on the right, the lower right. That is a diaphragm. So the way that it works is it holds spermicide in that little cup, holds the spermicide right up against the cervix. So not so much a physical barrier, but it just keeps the cervix and spermicide. What's new about the diaphragm, I mean, there have been diaphragms around for decades, but what's new about this is what's called a one size fits most. And so in the old days, we used to have people come in and be fitted to find out which size diaphragm they should have. But now you don't need to be fitted. Almost everybody can use this. It's available by prescription and covered by insurance. Most insurance, it just needs to be ordered by a clinician. But it's made a lot easier not having to have an appointment to have it fitted. So these work by preventing contact of sperm and egg. The condoms, internal and external, help protect against STDs. No prescription needed for spermicides and condoms, and limited side effects. The downside is that they can just take some work. The diaphragm takes some work. You need to put spermicide, like a tablespoon, in the cup. You need to put it around the rim, and you need to put it into place. If more than a half an hour goes by after sex, then you need to add more spermicide, and then it needs to stay in place for 6 hours after sex. So it does take some work, but every year, I have a couple of people who find that that is the best method for them. So the best method for you is the one that has the features that you like, some of the non-birth control benefits, and one that you can manage and that you feel good about. So some of the non-birth control benefits, again, pill, patch, and ring help decrease acne. Any hormonal method helps decrease painful or heavy periods. The pills help reduce the risk of ovarian and uterine cancer, and as well as the IUD. The IUDs reduce risk for uterine cancer as well. And then just another note for trans men sometimes will want a method that can stop their period. So you can use pills or the ring to stop your period, or maybe get an IUD that really decreases the period. So those are another non-birth control related benefit. And then there's also emergency contraception that you can take to help reduce your risk of pregnancy after the fact. Okay, one of the issues of the long-acting reversible methods, the IUDs and the implant, is that people do stop using condoms with them. But, you know, condoms are something that we need to think of other ways to help protect against sexually transmitted infection. It's not just adolescents who don't use them, who don't like them. Okay, so if you want more information about birth control methods, bedsider.org. This website is really good, accurate. And then I like this app called My Birth Control. I think it's, .org, because it asks you a bunch of questions about what you're looking for in a birth control method. And then it comes up with ideas. And again, it has accurate information. So that's all I really had. I know I kind of flew through that, but I also know there's only so much you can take in one day. So if you have any questions for me, I can hang around, or you can start your movie early, whatever you want. The other possibility would be to put on the TED Talk. You know, it's about 8 minutes, but what do you think, Jamie? What would you like to do?
Let's see. They have about 18 minutes before their film, so we've got. Maybe you could put on the TED Talk. It's kind of a cute way to end things, and maybe if anybody did have a question, they could type it in and
Okay.
then time. There is a question before we did that from Maddie here that maybe you could answer.
Okay, sure.
That STI testing at Tang seems to be halted. How would they be
okay?
Able to testing? So
first, LARC means long-acting reversible contraception. Basically, LARC is IUD and implant, and then STI testing. So COVID has really changed how we are practicing, and it's continuing to change. So everything is very fluid. The services are very fluid, but not only at Tang, but I think that in primary care medicine nationwide, there has been a move to stop some of what we call the healthcare maintenance or general healthcare, routine healthcare, preventative healthcare. That's the word I'm looking for, just to limit people from potential exposure to COVID. So keeping people out of healthcare centers. So what stopped at Tang was we used to have what's called self-directed STI testing, which you could just kind of order your own tests. You didn't need to see a clinician. And so there's been a hold on that. If somebody needs STI testing, that's certainly still available at Tang, and they can make even just a phone appointment to talk about it. And we're hoping to add back some of those services that have been halted, just given how long this thing is going to go on. People need services. We were just talking about that this morning. And then the patch. So the patch, it's about like that big, and it has an adhesive that is imbued with synthetic version of estrogen and progesterone. So just like the birth control pill. And it's on time release. So they've done studies to know that it releases a certain amount of hormone, all the time. The hormone gets absorbed through the skin into the blood system. So the birth control pill goes through the stomach into the blood. The patch goes through the skin into the blood. So it works the same way as the birth control pill, but you don't have to deal with it daily. So you're changing a patch once a week. So each patch is good for a week. So you leave it on for a week, and then you're changing one patch a week for 3 weeks, and then you go 1 week patch free. So it's just a non-daily alternative to the pill, and it has similar benefits to the birth control pill.
I had just one question, so maybe on topic, maybe not, but there was some controversy a little while back in certain states about the morning after pill. Have we gotten past that now? And is morning after pill?
There was a lot of concern around is there a higher risk for the ring or the patch for a risk of a blood clot? So any method that has estrogen in it has a risk for a blood clot. But most people are so low risk for a blood clot in general that it's not considered significant for the majority of people. So some researchers looked at data and thought that they saw that the patch had a much higher risk of blood clot compared to one type of birth control pill. But I think the larger community of people who, researchers in contraception, feel like their analysis was flawed. And even if you do take that their findings at face value, it's still a very small risk of a blood clot for the patch or the ring. So if you take their data, you could say that maybe 100 women out of 100,000 would get a blood clot on the patch compared to maybe 30 women out of 100,000 with one type of birth control pill. So still low numbers. So it's not risk-free. That's true. And we talk about that. And that's another reason that IUDs and implants are great, because they have absolutely no risk of blood clot. And to back up, a blood clot is potentially life-threatening. So they're uncommon, but they can be potentially really serious.
You see the question about Plan B?
Oh yeah, I don't know where it is a myth. There's some myth out there that you can there's a certain lifetime cap on how many times you can take Plan B. You could take it daily and it's safe. You wouldn't like how you felt, and it's not the most effective method, but I'm not sure quite where that came from. I think it's that if somebody is using it often, it's not that it's not safe, it's just that it's not very effective if that's your main method of birth control. It's Plan B. Plan A is something more effective, even condoms. And then because it's given just as kind of single dose, most people don't really have bad side effects. The question about acne, some birth control methods can cause acne. I see that there are certain birth control pills that maybe aren't as good at helping with it. The Depo-Provera shot is one that has potential to cause acne. The estrogen-free birth control pill can cause acne. It's listed as a possibility with the IUDs and implants, but the amount of hormone in those is very, very low. So it's not something that I see very often. So I'm going to stop sharing and then reshare. And then I'll play this and I'll still look for questions at the end. This is only about 8 minutes.
Okay, that sounds great. Let me ask questions closed then while we're watching the chat video.
I'd like to talk to you today about a whole new way to think about sexual activity and sexuality education by comparison. If you talk to someone today in America about sexual activity, you'll find pretty soon you're not just talking about sexual activity, you're also talking about baseball. Because baseball is the dominant cultural metaphor that Americans use to think about and talk about sexual activity. And we know that because there's all this language in English that seems to be talking about baseball, but that's really talking about sexual activity. So for example, you could be a pitcher or a catcher, and that corresponds to whether you perform a sexual act or receive a sexual act. Of course, there are the bases, which refer to specific sexual activities that happen in a very specific order. ultimately resulting in us scoring a run or hitting a home run, which is usually having vaginal intercourse to the point of orgasm, at least for the guy. You can strike out, which means you don't get to have any sexual activity. And if you're a bench warmer, you might be a virgin or somebody for whom whatever reason isn't in the game, maybe because of your age or because of your ability or because of your skill set. A bat's a penis, and a nappy dugout is a vulva or a vagina. A glove or a catcher's mitt is a condom. A switch hitter is a bisexual person, and we gay and lesbian folks play for the other team. And then there's this one. If there's grass on the field, play ball. And that usually refers to if a young person, specifically often a young woman, is old enough to have pubic hair, she's old enough to have sex with. This baseball model is incredibly problematic. It's sexist, it's heterosexist, it's competitive, it's goal-directed, and it can't result in healthy sexuality developing in young people or in adults. So we need a new model. I'm here today to offer you that new model, and it's based on pizza. Now, pizza is something that is universally understood and that most people associate with a positive experience. So let's do this. Let's take baseball and pizza and compare it when talking about three aspects of sexual activity: the trigger for sexual activity, what happens during sexual activity, and the expected outcome of sexual activity. So, when do you play baseball? You play baseball when it's baseball season and when there's a game on the schedule. It's not exactly your choice. So if it's prom night or a wedding night or at a party or if our parents aren't home, hey, it's just batter up. Can you imagine saying to your coach, not really feeling it today. I think I'll sit this game out. That's just not the way it happens. And when you get together to play baseball, immediately you're with two opposing teams. One playing offense, one playing defense. Somebody's trying to move deeper into the field. That's usually assigned to the boy. Somebody's trying to defend people moving into the field. That's often given to the girl. It's competitive. We're not playing with each other. We're playing against each other. And when you show up to play baseball, nobody needs to talk about what we're going to do or how this baseball game might be good for us. Everybody knows the rules. You just take your position and play the game. But when do you have pizza? Well, you have pizza when you're hungry for pizza. It starts with an internal sense, an internal desire, or a need. I could go for some pizza. And because it's an internal desire, we actually have some sense of control over that. I can decide that I'm hungry, but know that it's not a great time to eat. And then when we get together with someone for pizza, we're not competing with them. We're looking for an experience that both of us will share that's satisfying for both of us. And when you get together for pizza with somebody, what's the first thing you do? You talk about it. You talk about what you want. You talk about what you like. You may even negotiate. How do you feel about pepperoni? Not so much. I'm kind of a mushroom guy myself. Well, maybe we can go half and half. And even if you've had pizza with somebody for a very long time, don't you still say things like, should we get the usual? Or maybe something a little more adventurous. Okay, so when you're playing baseball, so if you talk about during sexual activity, when you're playing baseball, you're just supposed to round the bases in the proper order, one at a time. You can't hit the ball and run to right field. That doesn't work. And you also can't get to second base and say, I like it here. I'm going to stay here. No. And also, of course, with baseball, there's like the specific equipment and a specific skill set. Not everybody can play baseball. It's pretty exclusive. Okay, but what about pizza? When we're trying to figure out what's good for pizza, isn't it all about what's our pleasure? There are a million different kinds of pizza. There's a million different toppings. There's a million different ways to eat pizza. And none of them are wrong. They're different. And in this case, difference is good because that's going to increase the chance that we're having a satisfying experience. And lastly, what's the expected outcome of baseball? Well, in baseball, you play to win. You score as many runs as you can. There's always a winner in baseball, and that means there's always a loser in baseball. But what about pizza? Well, in pizza, we're not really, there's no winning. How do you win pizza? You don't. But you do look for, are we satisfied? And sometimes that can be different amounts over different times or with different people or in different days. And we get to decide when we feel satisfied. If we're still hungry, we might have some more. If you eat too much, though, you just feel gross. So what if we could take this pizza model and overlay it on top of sexuality education? A lot of sexuality education that happens today is so influenced by the baseball model, and it sets up education that can't help but produce unhealthy sexuality in young people, and those young people become older people. But if we could create sexuality education that was more like pizza, we could create education that invites people to think about their own desires, to make deliberate decisions about what they want, to talk about it with their partners, and to ultimately look for not some external outcome, but for what feels satisfying. And we get to decide that. You may have noticed in the baseball and pizza comparison, under the baseball, it's all commands. They're all exclamation points. But under the pizza model, they're questions. And who gets to answer those questions? You do. I do. So remember, when we're thinking about sexuality education and sexual activity, baseball, you're out. Pizza is the way to think about healthy, satisfying sexual activity and good comprehensive sexuality education. Thank you very much for your time.
Okay.
Okay, I didn't see any more. That was cute, by the way. I didn't see any more questions come in from students during the film. So I guess we can wrap here. It's coming up on 3:30, and the students have a film to watch at 3:30, so they could take a couple-minute break before that. Is there any way that if they had follow-up questions, they could get a hold of you?
Yes.
Yeah.
So if you have a specific personal thing, then I would recommend make an appointment at Tang. But if you have some general questions, then you can email me at mdeal@Berkeley. I'm happy to get back to you.
Okay, this was really great. You covered a lot in a short amount of time, and you know, I just like last year, I learned a couple new things this year too. So thank you for making the time to be with us today. And for the students in the class, you have the option if you'd like to watch the film that we have coming up, queued up for you at 3:30. The link is going to show up in an announcement for you at 3:30. And if you don't want to watch that, there's not a penalty for not watching it. And we'll see you guys on Tuesday of next week. And want to thank you again, Melanie, for being with us today.
Thank you. It was a lot of fun. Thanks.
Take care, everybody.
Bye.
Okay, bye-bye.
Bye.